Hi, everyone. Thanks for tuning in. Today, we are going to talk a little bit about vasopressors. So, for those of you who work in the ICU, you may already be pretty familiar with vasopressors. Typically, when I teach this class, I like to go a little bit further into what is kind of the mechanism of action of these medicines, how do they work within the body, what is the onset of these medicines, and then the duration of the different vasopressors. And usually when I teach this, I like to ask people, what is it that you would like to know more about? What questions do you have about when you have a patient on pressors? And oftentimes what I get is, how do we know which drug to use? When? So how do I know which vasopressor I'm going to use on this patient when I might select a different vasopressor for a different patient? And that's really the big question. And of course, kind of following up on that one is if I have a patient on multiple vasopressors, which one of these am I going to titrate first? And so, by covering the mechanism of action, the onset and duration, we're going to answer some of these questions that are very commonly asked. And if you have other questions, please feel free to let me know. You can write them in the comment section or reach out to me otherwise. And I will be honest with you guys, I'm going to get rid of that. The first time somebody taught me about vasopressors in the way that I'm about to teach you, I was a brand new nurse, a brand new ICU nurse. I had worked in acute care for a little while, and it was my first day or first week in the ICU, and I happened to be orienting that day with a nurse a CRNA, for those of us who can't pronounce anesthetist, who happened to be working at the bedside. And they rattled off to me how, the patient who came out of the operating room was very, very sick, came out on 3 or 4 different pressors, some dilators also being hung, and really rattled off to me over, over the patient as trying to get trying to get them settled in from the operating room, and rattled off to me, oh, and this one works this way, this one works that way. And I remember thinking in that moment, I have no idea what you're talking about. And I remember thinking, that's great that that's the way that you learned it and that works for you. And also, like, you're a CRNA and it's my first week in the critical care world. And I remember thinking, I'm never going to learn it that way. I'm never going to remember which drugs work on which receptors and how long they last and why we should choose that one. And you know what? I'm sort of okay with that right now, because at that point I was just trying to keep my head above water. And I'm not sure if it is, the fact that I thought, well, that's really nice for you, but I don't learn that way, that actually helped me remember this. But over time, what I've learned is that if you can learn drugs this way, if you can learn vasopressors by learning how they work in the body, it will answer so many of the questions that you have about about the decisions that we make clinically when we select these medicines. And I will tell you, this presentation that I'm going to do is a little bit simplified, and I have had people come back afterwards and tell me, well, actually this also works on these receptors and it also does this. And to just kind of put it out there ahead of time, the way that the mechanism of action and the way that these medicines work can be incredibly complicated, and we could spend all day talking about it. But at the baseline, what I'm going to highlight is what is clinically relevant. If I am just learning these medicines and trying to really dive deep into them, what are the most clinically relevant things for me to know if I'm titrating these or I'm managing these medicines? So to start off, we're going to talk about what are some of the most common vasopressors. And I'm also going to do, we'll start off with these kind of 5, I think are probably the most common ones that we'll see. Okay, so let's start off with one of the most common ones. We've got norepinephrine. which some of you may be more familiar with calling it Levophed. All right, so that's one. And then we've got epinephrine. All right, we've got phenylephrine, also known as neosynephrine. So I'm just going to abbreviate neo. So I've got norepinephrine, epinephrine, phenylephrine. I'm going to throw dopamine in here. And I'm going to throw vasopressin in here. So I'm going to exclude probably the next most common vasopressor that we talk about, which is Giopresa or angiotensin 2. I'm going to kind of exclude that one just for the purposes of this talk. Not a lot of places are necessarily widely using it. And we're going to make ourselves a nice kind of graph here. And this graph is really, this is something that I like to give to people in a kind of a badge version so that they can utilize it while they're at the bedside. I think it's really helpful. It's a quick overview, not a ton of details, but enough to kind of give you the information that you need in a very quick and time efficient manner. All right, so now here at the very top across this, I'm going to put some letters. I've got A1, B1, B2, DA, and then I'm going to say this will be my onset and my duration over here. Okay. All right, so you'll notice I have A1, B1, B2, and DA. So these are going to be our receptors that we're talking about when we talk about vasopressors. So to start off, one of the most important things we need to do is figure out where are these receptors. So A1, what does A1 stand for? A1 very simply stands for alpha. So alpha 1. And like I said before, you know, these receptors are going to be located in various parts of the body, but predominantly what we're going to look at is alpha 1 and how it affects in our periphery. Okay, so this is in our peripheral. So the next one I have up here, this is going to be B1. All right, and what does B1 stand for? Of course, B1 stands for beta 1. And where does beta 1 sit? Where's beta 1 located? This is going to be in the heart. Okay, so this is our beta blockers for the heart. And then B2, this is going to be our beta 2 receptors, and these are going to be in our lungs. So one of the ways that I've heard some people remember this is you have one heart and two lungs, so that's how they differentiate between beta 1 and beta 2. And the very last one that I've got up here is DA, and DA can stand for a handful of things, but in this scenario, it's going to stand for dopaminergic. So our dopamine receptors, where are those going to be located? Now, when I hear dopamine receptors, my first instinct is, ooh, the brain, right? We learn all about dopamine in the brain. That's the feel-good chemical. But dopamine is also present in a variety of other places. It has a role in the kidneys. It has a role in the periphery. So dopamine is a little bit of kind of scattered all over the place. And the easiest way for me to think about this is DA, because it is so scattered, I like to think about this as being a little bit of everywhere. All right. So we've got our receptors up here, alpha 1, beta 2, dopaminergic, and now we know where each of those 4 receptors are located. So let's start off and let's move through this graph together. And what we're going to do is just put X's on the medicines in which receptors they affect. So one of the easiest ways to think about this is for our alpha 1 receptor right here. Keep in mind this is located in the periphery. So this is in the peripheral space. Now, where do we measure blood pressure from usually? oftentimes we have a blood pressure cuff that's somewhere on the arm. Okay, so the arm is part of the periphery. Perhaps we have an arterial line that is in the radial artery, that is a peripheral artery. So when I think about alpha 1 and I think about its effect on the body, I think anything that is going to cause my blood pressure to go up pretty quickly, or anything that I'm going to see a direct effect on just my blood pressure, my peripheral blood pressure, I can almost safely assume that it affects my alpha 1 receptor. So that's not always true, but for the most part, that's a relatively safe assumption to go by. Okay, so let's start with norepinephrine. Okay, so does norepinephrine increase my blood pressure? Yes, it does. So we know that that's going to be an alpha 1 contact. And something to just kind of help you remember norepinephrine is that when a patient's on norepinephrine, one of the things that we worry about is an elevated heart rate. So if there's a medicine that has the risk factors of really elevating a heart rate, that's a vasopressor like this, chances are it also affects the beta 1, the heart, the receptors on the heart. And a way that's really easy for me to remember that is that this has this epinephrine kind of in the end part of it. So it does have a little bit of similarities. Of course, epinephrine being, we know that that it definitely hits beta 1 if we think about the fact that we give epinephrine to individuals who are in cardiac arrest. So we know that's definitely a beta 1. And we also know that epinephrine is going to very rapidly increase someone's blood pressure if it's given. All right, so we've got norepinephrine with alpha 1 and beta 1, and we're going to kind of leave norepinephrine at those two. With epinephrine down here, we've got alpha 1 and beta 1, and we're also going to add in beta 2 here with epinephrine. So how do I know epinephrine hits the beta 2 receptors in the lungs? So if I think about a patient, if any of you guys have ever heard of racemic epi, this is an inhaled version of epinephrine that actually causes a bronchodilation. So this is something that you may give to patients who are having airway swelling, perhaps maybe from a reaction of some sort. The most oftentimes I see the need for racemic epinephrine or inhaled epinephrine in the adult ICU world is usually with patients who self-extubate themselves, who pull their own endotracheal tubes out with the cuffs still inflated, and that tends to result sometimes in some damage to the airway, some trauma to the airway, and can result in just some immediate airway swelling. And so what you hear when these people try to, they rip their endotracheal tube out, and what do you hear? The next breath out of their mouth sounds very kind of difficult. It's kind of a stridor that you're looking for. And if the stridor is too severe, or the patient is not going to tolerate not being on a ventilator, of course, that would indicate that we might need to re-intubate them. But if the swelling can be managed with some racemic epinephrine, that's of course an easier route to take if it's appropriate for that patient. Okay, so phenylephrine. Let's talk about phenylephrine. Phenylephrine is kind of unique. Phenylephrine, or neo, is actually a pure alpha 1 agonist. So it only hits the alpha 1 receptor. And we'll talk about what the benefit is and why you might use phenylephrine over a different medicine at some point in time. And then lastly, I'm just going to, whoops. Oh, dang it. All right, moving on to dopamine. So chances are, probably, for me, the easiest way to remember dopamine is, of course, we know that, of course, it's going to hit the dopaminergic receptor. That makes sense. But if we look at where these dopamine receptors are, and they're sort of scattered a little bit of everywhere in multiple places around the body, that helps me remember that dopamine is everywhere. Dopamine is also going everywhere. Alpha 1, beta 2, dopaminergic receptors. It's sort of spreading throughout the entire system. And then vasopressin is a little bit different. Vasopressor, I'm actually just going to strike a line through right here. It is actually not a receptor-based drug. So we'll talk about vasopressin in a little bit more detail in just a second. So let me go ahead and I think you guys probably got this. Remember, alpha 1 in the periphery, beta 1 in the heart, beta 2 in the lungs, and dopaminergic a little bit of everywhere. Okay. So, whoops, forgot this one. So when we look at vasopressin, something interesting about vasopressin. So like I said, this is not a receptor-based drug. That means that it does not hit the traditional receptors that a vasopressor does. It does not hit our alpha 1, beta 2. And vasopressin, uniquely enough, is actually what this is called when we give it exogenously, when we give it through an IV to a patient. However, patients, we all actually make a form of vasopressin endogenously. We make a form of vasopressin internally, but we don't call it vasopressin when we actually make it. We call it something else. And so vasopressin is essentially ADH. You guys remember what ADH is? This is pulling way back all the way to some biology classes. So ADH is the anti-diuretic, I can't spell, diuretic hormone. Okay, so what does ADH do? Quite simply, antidiuretic hormone causes an increase in fluid retention and causes vasoconstriction across the system, starting in the renal system. Okay, so I'm not going to go into too much detail on how vasopressin works, but I do want to point out that it does cause vasoconstriction and it is a hormone, okay? All right, so this is pretty simply kind of what our chart is going to look like. And now I want to kind of go back and fill in the last column that we haven't talked about, which is onset and duration. And something to think about is, if I'm the nurse titrating these medicines, the onset and duration might be some of the most helpful information for you to remember. And really that is because if I'm titrating these medicines, it is really helpful for me to know how long does it take for this medicine to kick in and how long does it take for this medicine to wear off. Because if I am titrating it before it has had a chance to really, for me to see the effect of that first titration in the patient, this is where we end up kind of chasing blood pressures all day with vasopressors. We're titrating them too quickly and we don't really allow the patient to have the response. And so let's look real quick at norepinephrine. So norepinephrine, it has a for anyone who's used Levophed, you know that this is a relatively quick onset with also a relatively short duration, and that tends to be somewhat of a rule of thumb with medicines. Quick on, quick off, not always the case, but relatively common. So norepinephrine, we're looking at, an onset somewhere most likely within the first 60 seconds. So that means when I say onset, I mean, if I have an arterial line, I'm going to have started to see the effects of my titration somewhere within the first, and I'm going to write that a little bit differently, and say within the first, 1 to 2 minutes, I'm definitely going to have started to really see the effects of that. And when we look at how long that takes to wear off, I'm looking somewhere in the 5-minute range. At 5 minutes, chances are my norepinephrine will have most likely worn off. And you guys, this can be a little bit different dependent on your patient. There are some patients who are very, very sensitive to certain medicines, some patients who are not sensitive at all. So this is really just kind of a generic overview at how these medicines operate. And just to kind of put it in terms that are easy to remember, and for the most part, just kind of a helpful generic guideline. Okay, so let's look at epinephrine. Okay, so how long does it take epinephrine to kick in? Epinephrine kicks in pretty quickly, right? Epinephrine kicks in pretty quickly. If you've ever given epinephrine in a code, you know that it really starts to kick in pretty quickly. I'm going to be looking at something around, God, I keep wanting to write minutes and I keep writing seconds. Something around a minute. It's going to have really started to kick in. And for duration for epinephrine, if you're on a drip, this can sort of be extended a little bit out to 10 minutes or so. But for the most part, the way that I think about epinephrine is we give epinephrine every 3 to 5 minutes in a code. So the duration there it is somewhere around kind of 5 minutes on that. Okay, so phenylephrine. Phenylephrine was a little bit unique. It is a pure alpha-1 agonist, so it only hits the periphery. So what does that mean with phenylephrine? Phenylephrine is going to have a little bit of a longer onset because it's got to travel all the way down to the periphery. So when we administer these first two drugs, norepinephrine, epinephrine, they're going to hit, remember, they hit the heart at beta 1, and then sort of travel out towards alpha-1 into the periphery. So phenylephrine is going to have a little bit of a delayed response. So when we talk about onset for phenylephrine, you're looking at something a little bit longer, something maybe, 5-ish minutes, maybe even a little bit longer before you actually see an effect of phenylephrine happening. And I'd say probably roughly 7. I'm going to put 5 to 10 just as an average. And for duration for phenylephrine, this can be anywhere from 10 to 20 minutes, depending on the patient and depending on dosages and what else the patient's on. So I want you to just notice something really, really different here, a 5-minute duration versus upwards of a 20-minute duration. So that's a really significant difference. And I will tell you, we typically, I don't see a whole lot of phenylephrine use in certain patient populations. I see a lot of norepinephrine use. That is kind of the vasopressor of choice in the department that I work in. And what happens sometimes is we get very, very accustomed to titrating norepinephrine, which is fast on, fast off, quick onset, relatively quick duration. And what happens when we get a patient who is on neo, who's on phenylephrine down here, is we titrate it very similarly to how we titrate norepinephrine, and then we end up in trouble. And so, expecting this familiar 5-minute duration, we may titrate phenylephrine a little bit faster than we probably need to, and we end up having multiple titrations before the first titration even kicks in. So just something to be very, very aware of. The other thing to be very aware of when we talk about phenylephrine is look at this onset, okay? This 5 to 10 minute onset. I can't tell you how many times I have heard throughout the course of my career in critical care environments is, I need somebody to get me an emergent bag of phenylephrine. So an emergent bag of phenylephrine to me communicates, yes, we really need a vasopressor available, and we, need it very quickly. However, if my patient's blood pressure is 60/40, is phenylephrine going to be my top choice drug? No. it's not. Phenylephrine is not going to be the drug that I go to titrate first, and it's not going to be the drug that I look to start first because of its longer onset time. So if my patient is in imminent danger of losing a pulse because their blood pressure is low, I'm going to be looking for a drug that works very, very fast. I'm going to be looking for something like norepinephrine or epinephrine that has a very quick onset. Now, that is not to say that phenylephrine is not a great additive. It certainly has its place and can be very effective when it's used properly. But typically in an emergency situation where someone is in imminent danger of cardiac arrest due to hypotension, phenylephrine is infrequently needs to be the medicine that we go to first. So I'll spend a little bit more time talking about the choice of phenylephrine over norepinephrine in just a minute, but I want to finish filling out this chart first. So looking at dopamine, okay, so we know that dopamine hits all the receptors that we have listed. We've got our alpha 1, beta 1, beta 2, so we're hitting the periphery, we're hitting the lungs, we're hitting the heart, we're hitting the dopaminergic receptors. And dopamine really tends to have, because it is traveling everywhere, you will start to see some effects of dopamine very quickly. You will start to see some effects within the first couple of minutes, but you really won't begin to see the full effects for quite some time because it's got to travel everywhere. And some of those effects may even be a little delayed. So some of those effects you might not see for 15 minutes or 20 minutes, but you should start to see effects relatively fast. And then the duration, because it is everywhere, remember, it takes a little bit longer for things to kind of wear off, essentially. And so this is when you start to see things, upwards of, you'll see most of your effects wear off within 10 minutes, and almost all of them wear off within about half an hour. Once again, there may be some delay in that. To be honest with you guys, I rarely use dopamine as a vasopressor. If dopamine is a drug that a patient is on and it's been chosen appropriately, it's most likely going to be being used as an inotrope, in which case it is not titratable by RNs. Nurses really don't titrate inotropes unless they have extremely strict parameters that they're following in a protocol. So why did I include it in the vasopressor talk and not the inotrope talk? Well, dopamine historically was the first line vasopressor that was used. And so for those of you who've been in practice for many years or have trained with someone who's been in practice many years, you may have heard the phrase, better dead than leave a fed. And 20 years ago, everybody in healthcare, maybe not everybody, but a lot of people in healthcare thought, oh, norepinephrine, if you're on norepinephrine, it was sort of the last thing we added, and you were close to death and you were imminently going to die. And one of the things that we've learned over time is the difference in how these medicines works, and studied, lots of outcome trials and things like that. And what we've learned is that patients who are on dopamine very early in their course for vasopressor use have much worse outcomes than patients who are on norepinephrine. The use of long-term high-dose dopamine is associated with an increase, a pretty significant, I can't recall the statistic off the top of my head, but a pretty significant increase in ventricular tachyarrhythmias because it is so irritating to the heart. So why include this? I include it because it used to be the first line drug. It is still the first line vasopressor in many areas of the world and many areas of the country and even many areas of the state. So dopamine has a couple benefits that the other vasopressors do not have, one of which is that it is cheap. It is much cheaper. The next benefit is that it is stable on the shelf. It has a shelf life. Most of these other medicines that are being made are very expensive to pre-make. They expire fast. And so dopamine is very readily available in crash carts, smaller and more rural environments, in EMS and transport type situations. And so it's not uncommon. Of course, I'm in a large academic medical facility. We don't use dopamine for vasopressors, but it's not uncommon to get patients transferred to us who are on dopamine from either, ambulance transport or coming in from a different facility, things like that. And typically our practice is to wean them off the dopamine and start them on norepinephrine as we can. So I did want to mention just a little bit about that. And then, of course, vasopressin, we talked about a little bit earlier, an antidiuretic hormone. So this is a hormone, meaning that our hormones typically aren't doing a whole lot of things fast. So this is going to have a much longer onset and a much longer duration. We're going to look somewhere in the 20 to 30 minutes, oftentimes even longer to really see a full effect here. And for duration, we're going to be looking somewhere around an hour, sometimes even 2. So this is another one of those vasopressors where I really discourage people from asking for an emergent bag of vasopressin. Now, if you need a bag of vasopressin very quickly, then I'm not saying that that's not appropriate, that you really don't need that bag. But what I want to get the point across is that if your patient's blood pressure is 60/40 and they are in imminent danger of dying due to a low blood pressure, the first drug that you want to go to is not vasopressin, because there's hardly anything emergent about 20 minutes. In 20 minutes, they'll be coding. So I really encourage you guys, vasopressin and phenylephrine are wonderful medicines, but I encourage you, as far as emergency management goes, those 2 drugs are typically really not the ones that you want to grab right off the bat. You want to get something into the patient's system quickly so you can get them a little bit more stable and then get those additional supports on board if that is appropriate for the patient. Okay, so far we have covered the 5 most common vasopressors that are used in the ICU. We've covered their mechanism of actions as far as receptors go, and we've covered the onset and duration. So the last thing that I want to review with you guys is how these receptors work and kind of the best way to think about it. So what I sort of envision when I think about receptors, and just as a sort of plug here, this is physiologically not accurate in any sort of way, but it is helpful as far as a understanding, kind of a visual aid type deal. Okay, so we're going to switch over to the next page. Now I want I'm going to talk about this this receptor right here, this beta-1 receptor. Okay, so I'm going to take this beta-1 receptor right here, beta-1, and I'm going to pretend that this beta-1 receptor is a table, and at this table I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seats at the table. Okay, 10 seats. So what you'll notice about this beta-1 receptor is that there are several drugs, norepinephrine, epinephrine, some of the inotrope medicines will be activating to the beta-1 receptor, hit the beta-1 receptor. And remember, where is this beta-1 receptor? This is on the heart, okay? So how do I know if my beta-1 receptor is irritated? This is pretty simple. I'm going to have changes in my heart rate, okay? So in this scenario, I'm going to have a patient who, let's say, is on, I'm going to abbreviate and say that they are on levo, and they're on, let's say, 0.3 mics per kg per minute. Actually, I'm going to change this to 0.1. We'll start off a little bit lower. So 0.1 mics per kg per minute. So at the beta 1 table here, that is the receptor sitting on the heart, I am now starting to see some levophed come to sit down. So levophed is going to, at 0.1, going to take up, let's say, 3 of the seats at the table. Okay, but let's say, hey, you know, this patient, and actually, let's say at this point, our, you know, patient's heart rate is, let's say, it, that's a terrible 8. Oh no. Let me get that back. Let's say is at 80 in a sinus rhythm. Okay. So patient's still a little hypotensive, not loving what I see. I'm gonna go ahead and up titrate on my levo, and now we're gonna go to 0.2, and we're just taking little snapshots, mics per kg per minute. And at this point, now this patient's heart rate has also gone up. Their heart rate is now at 100, and levophed has taken up, let's say, 3 more seats at the table. Okay, and same situation, I'm gonna have to continue to up titrate on my levo. Now my levophed is at 0.3, and my heart rate is now at 120, and I'm really starting to see just a few sort of PACs, some preatrial contractions, maybe a few PVCs, but nothing super dangerous yet. I'm just kind of keeping an eye on it, starting to be aware. And I've got now levophed at 3 more seats at the table. And now my patient is continuing to be hypotensive. Now I've got my levo. Maybe they've ordered some other pressors. They're not up from pharmacy. Now I've got my levophed at 0.5. And by the way, you guys, we don't titrate, as far as titration goes of levophed, typically you're not going up 0.1 to 0.2. Typically there are several titrations in between that, just from a safety standpoint, if you're unfamiliar with titration of levophed. So now I've got my levophed at 0.5, and my heart rate is, let's say, 140, and I'm now having really frequent PVCs, maybe short runs of BTAC. So what I'm seeing, and I have here's levo, and then I just start to gather sort of this irritation side. So the way that I visually picture receptors and receptor-based drugs, like I said, physiologically not super accurate, but the way that I picture it is that we are now on at 0.5. Typically our clinical max, sort of where we assess is levophed continuing to be an effective medicine for this person, is typically around 0.3. So in this scenario, we've decided to continue going up for whatever reason. And now I've got them at 0.5. And what's happened is my beta 1 receptors is sort of maxed out. And this is when I talk about the beta 1 receptor being quote unquote maxed out, what I'm referring to is the beta 1 receptor on what I want it to do. Okay, so what I want it to do is have an improvement in contractility. Okay, that is what I want to happen. I want to support that heart just a little bit, give it a little bit of extra help, let it squeeze more effectively, and so that's what the seats at the table represent. Now you'll notice that I have several other levopeds kind of sitting out here waiting on a table. So if you've ever been to a crowded restaurant, or you've been out to dinner with a group of people, I sort of think about this as, you know, a dinner table of 6 people is very pleasant. A dinner table of 20 people, I've never really had a good time at. You know, you can't talk to everybody, you can't see people, you end up sitting next to somebody that you don't really know, who was brought by a friend, and you're not even sure how, you know, who they came with anymore. And so we start to have this dinner experience at the beta 1 receptor table starts to become a little bit more unpleasant. Now I've got, there were only, the reservation was only for 6, and now there's 12 people. So we got people standing up behind you while you're trying to enjoy a conversation. So what we end up doing when we start adding these extra stimulation is we really start to get more of the negative side effects. So there's no more benefit at the beta 1 table, but what I am going to get is the signs of beta 1 overload, which is essentially too much stimulation on the beta 1 receptor. And everybody's different. There's no set number, set value, set amount of stimulation. Everybody's going to be a little bit different. But how do I know that I'm starting to find irritation on the beta 1? I'm going to start to have more sinus tach. I'm going to start to see perhaps some atrial arrhythmias, maybe some ventricular arrhythmias, certainly some PACs, some PVCs, any sign that the heart muscle is getting a little bit irritated. And so a lot of times we're going to see those changes in the electrical activity of the heart. So if your patient is already in AFib with a rapid ventricular rate, chances are we probably don't want to continue to irritate the heart. And so one of the other important things to recognize here when we talk about receptors and talk about stimulating receptors is that some people, if I already have a patient who is in atrial fibrillation with a rapid ventricular rate, they're in the 180s and also hypotensive, that the heart, the beta 1 receptors, already very stressed out. And what I don't want to do is add a medicine that's going to make it more stressed out. So this is where it becomes really helpful and important that we have vasopressors that do not stimulate the beta 1. So in this scenario, this is when it becomes very helpful that we have the option to use phenylephrine. So if I have a patient who is obviously irritated in their cardiac muscle, this is where I really consider, okay, phenylephrine may be the very, very best choice for them. And I know why, because what I don't want to do is take somebody who's in AFib in the 140s, start them on Levophed, and put them in AFib in the 180s. That's absolutely not what I don't want to do. And something interesting about neosynephrine is in higher doses, neosynephrine can actually cause sort of a reflex bradycardia. So it can actually lower the heart rate sometimes, which is just sort of an added benefit. So that kind of is sort of the choice behind why some people might like phenylephrine versus norepinephrine. And you might be thinking, well, why would I ever want to irritate the heart muscle? And why not use phenylephrine all the time, other than the fact that it's a little bit faster? So this is where we talk about why we would want to stimulate beta 1. As I'm going to kind of draw, this is my morning curve, okay? So I get up in the morning and I'm very, very sleepy. I'm a coffee drinker. I don't know about you guys. And my goal is to get right here. This is the pinnacle of my energy level, okay? So this is where I function the best, right there at the top of the curve. So this right here, this is my first cup of coffee, okay? First cup of coffee just gets me out of bed, gets me to the couch. The dogs still haven't been fed, and I'm really not having it yet. The second cup of coffee, okay, I can get my clothes on, feed the dogs, start to get ready for work. This third cup of coffee, for me, this is a really good spot for me to be in, this third cup of coffee. Well, some days I think, oh, well, 3 cups has me feeling really good, so why don't I continue to drink it? And then I end up this 4th cup. Now, if I keep drinking, I end up 5 cups down the curve. I'm starting to get a little anxious somewhere around here. And this 6th cup, I am now having a full-on panic attack. And I think I, have the stomach bug. So there is a sweet spot for receptors, just like there is for my morning coffee routine. The beta 1 receptor is the exact same way. The 10 seats at the table may have been right here, and then those other people that are standing around the table start to take us in this kind of negative direction. So we've gotten the most effectiveness that we can get from our levofed on that beta 1 receptor, or we've gotten the most effectiveness from that beta 1 receptor regardless of what medicines are on it. You know, this, for example, could have been epinephrine. This could have been epinephrine. The beta 1 receptor doesn't necessarily care, you know, which medicine is stimulating it. It's just the fact that it's being stimulated that it reads. So finding that sweet spot between enough stimulation, but not too much stimulation is really the goal of a lot of our receptor-based drugs that we're looking at when we talk about titrating. So that is also one of the reasons when we talk about the beta 1, you know, if we think about things that influence blood pressure, which is typically the primary reason we're on these medicines, things that influence blood pressure, when we think about blood pressure, and if you want more information on this concept that I'm about to talk about, there's a hemodynamics talk that you can visit as well that kind of goes into a little bit more detail. But when I think about blood pressure and blood pressure being low, the thing that I'm really wondering about is what is my cardiac output? Okay, so what is my cardiac output? And the equation for cardiac output is quite simple. It is heart rate times stroke volume. All right, so cardiac output, cardiac receptor. Really, for adults, the ideal heart rate to optimize cardiac output is somewhere between 90 and 110 for the most part with a healthy heart. So I do want to stimulate this beta 1 receptor because in order to get that heart rate up just a little bit, help give contractility so I can improve my cardiac output and improve my blood pressure. And that's really one of the reasons why norepinephrine tends to be kind of the drug of choice in a lot of scenarios, especially outside of patients that have cardiac irritability. Okay, so I know that was a lot of information. I know that there are other drugs that we give that cause changes in our blood pressure and our vascular status. And so I'm going to kind of stop right here, having reviewed the 5 most common. And then when we pick back up with vasoactive drugs, we will talk more about it from the standpoint of inotropes and then visit vasodilators. If you guys have questions, like I said, please let me know. Write it in the comments, reach out to me. I'm more than happy to answer them. I really hope that this information is helpful and that you can use it and apply it to your clinical practice.